want to talk about evidence. The concern about suicide this year didn't actually start with COVID. We were already worried about suicide rates. This is the updated figure on suicide rates in England. So you may have noticed that ONS, Office for National Statistics, brought out the most recent suicide data just a few weeks ago, about 5 weeks ago. And this slide is telling us what's in that report. So the middle line there, the blue line, is the one that it shows the general population rate. And let me just remind you then that around 2007, the suicide rate in England reached a record low. Then we saw a rise coinciding with the recession, the post-recession period. The threat of recessions to suicide figures is, of course, back at the moment. Then the rate started to go down, and we almost got back down to that record low when, in 2018, there was a 12% rise in the suicide rate. So that's a very large rise in a single year, followed in the new figures by a further 5% rise. Now, one factor is likely to be the lowering of the standard of proof at inquest, but it's probably not the only explanation. And there is a piece of work going on now. ONS themselves are examining factors that may have increased the rate over the last couple of years. So it makes an important point that when talking about how we recover from, in mental health terms, from the pandemic, we also need to bear in mind the situation we were already in. And that was one of rising suicide rates and increasing mental health pressures on at least some parts of the population. This then is the breakdown by age and sex for 2019. So this is, again, the most recent figures. What you can see here, some familiar things, I suppose, that the blue bars, that's males, the rate is 3 times higher in men than in women. And that the highest rate is in this group here, men in their early 40s and 50s. And they are, of course, a priority for this National Suicide Prevention Programme. We then see a second peak in older men. That's still there in the current figures. And even although the figures in young people are relatively low by comparison to other groups, these are at historic highs for young people. So the highest figure for at least 20 years, depending on which young people's group you examine. There is some good news as well, I suppose. Let me give you the positives. That in the change from 2018 to 2019, when the overall rate, remember, went up by 5%, most age and sex groups were affected to some extent. But the two exceptions were middle-aged men and people under the age of 20, in whom there was no rise in 2019. It so happens that those two are priorities for the national programme and have been over the last 3 years. But we shouldn't be too complacent about young people. This is the rate, national rate now, just in people under the age of 20. So here's what I just mentioned, the flat change from 2018 to 2019 in young people as a whole. But let's remember the long-term pattern here, which is a rise since around 2010. Not just in this country. There was a paper a few months ago reporting the social characteristics of countries in which this rise was also found. And the one that stood out was income inequality. And the one that didn't feature very strongly was use of social media. So this is an important phenomenon, this long-term rise in suicide in young people. And again, it just makes the point. Many people are worried about young people's mental health as we recover from COVID-19. And that's going to be a very important part of national well-being in the next year or 2 or 3. But we mustn't forget that young people were already facing difficulties, and the reasons for those difficulties have to be part of any recovery plan. Now, what about the work since the pandemic began? This is just to say something about the National Confidential Inquiry. Our work programme has changed quite substantially since the pandemic began. So first of all, we've taken on the support to STPs that we were already providing, now to include Wave 3. So as you will know, at least if you don't know, then you might be in the wrong meeting. This is what we're doing now. It's about webinars and advice and evidence to help STPs. It's a support. It's our way of supporting what you do in local suicide prevention. But in addition, because this was essentially a national emergency, we decided to extend our same support. We're still focusing on waves 1 to 3, but we also want to provide what we can for STPs that are not in the programme yet, for mental health trusts, and for mental health suicide prevention leaders, not just in England, but across the UK. Our support, the diagram there is our website where a lot of that support can be found, the emerging evidence, recent figures, and so on. Then we've been working on real-time surveillance. So as you'll know, we can't rely on inquest verdicts to tell us what's happening immediately about suicide statistics. The median time from death to registration of a death is 166 days. So we have to have a more immediate version of suicide recording, so-called real-time surveillance. And we're part of real-time surveillance on 3 groups, on the general population, where we work with Public Health England, on mental health patients, and on children. And I'll say a little bit more about children in a short while. And then there is a broader national suicide prevention response of which we're part. So again, that's working with PHE and NHS England, national charities and leading academic centres to put together a national response to the risk that some people may now face. So I want to spend the rest of my time just talking a little bit about that emerging evidence. Soon after the pandemic started, a number of us, so the Confidential Inquiry and others, work led by David Gunnell in Bristol, we got together to produce a commentary for the Lancet Psychiatry, in which we set out what we already know about suicide prevention and how that might be used at a time of pandemic. So again, remember that message. We know quite a lot about suicide prevention. We have quite a lot of research evidence and a lot of experience through national strategies. And that can be applied, even though the situation, almost it's a cliche now to say it's unprecedented, but it can, even so, those same principles, that same evidence can be applied to the new challenge. We can already say, for example, that people who may be most affected are those who are isolated, people facing economic stresses, those whose care is disrupted, people whose lives are marginalised by poverty, by ethnicity, or by disability. And that includes people with pre-existing mental health conditions. So a targeted approach, a strategic approach to suicide prevention, whether it's at national level or at local level, would address those groups, it would address those stressors. It would include people whose risk lay in being victims of domestic violence or alcohol, people who are traumatized by their experience under COVID, or bereaved. It would also include wider social approaches, creating economic support for people who might be vulnerable, people who providing a sense of well-being across the whole community, that sense of social cohesion that can support vulnerable people, and working with the media reporting, a very important part of prevention. So in our article, we set out what we thought a strategic approach should be about, based on evidence. There are also some figures. So this is a very useful survey carried out at UCL called the COVID Social Survey. This is a repeat survey of around 70,000 people. And in the survey, the people are, it's not a random sample of the population. So in that sense, it's probably better at showing us change than it is at showing us absolute levels. But it has told us how people are feeling, what their well-being is like, what their concerns are under the pandemic. And it reports every week. So it gives us an update on what's happened. So this is it's just a selected slide. This is showing the number of people reporting COVID stress. And like many surveys that are around at the moment, this one has found that on the whole, people reported feeling more stressed once lockdown began. So the beginning of these slides, so this point here is the beginning of lockdown. This point here, the dotted line, is the beginning of the easing of lockdown. And for many people, there was an initial period of stress, but that settled to some extent during the lockdown period. And other people have found something similar. It isn't equal across the community. So here is this particular graph is showing people who have a mental health diagnosis, and their level of COVID stress was greater than the population as a whole. It also asks about suicidal ideas and recent self-harm. And the most important message, I suppose, is that it hasn't found that the population is reporting increasing self-harm since lockdown or easing began. It does report that some groups are more vulnerable than others. So again, people with a mental health diagnosis, higher rates of self-harm, younger people up here, higher rates, some volatility in the figures there. But in general, no change during the lockdown and post-lockdown period. Another national survey by ONS, Office for National Statistics, similar kind of design, but this time measuring anxiety in a more formal way, and finding that a number of groups were prone to anxiety. Again, finding that point that people were more anxious in the initial period, then it began to settle. But some groups more affected than others. And in the ONS survey, the groups more affected were people who were, first of all, women, people who were in marriages or civil partnerships. And this, the sense from ONS was that this was about balancing the work pressures and family pressures that was causing greater anxiety to that group, who on the whole are better protected under normal circumstances. And also people who were more disabled. So some groups more affected than others, but the strongest driver of anxiety was this point here, and that's about feeling lonely. So loneliness at the heart of a number of these differences in the population. There are also some rather innovative approaches to data. This is a study carried out by at Bristol University, a colleague called Dee Knipe, who's been monitoring Google searches, so the reasons people search on the internet for certain topics. These are all mental health topics. And just to orient you, the line C here is the point of lockdown. So the green line is the proportion of searches which are about suicide. Yellow is self-harm. And again, similar to the self-harm data, no increase during the post-lockdown period. Now, it can be difficult to interpret Google search trying to do it. So knowing exactly what it signifies about population well-being is more difficult. But it does respond to what people are concerned about. And the proof here is this line here, where there was a peak. This has nothing to do with COVID. This is a peak before COVID, just after the highly publicized death of a TV celebrity. So searches do respond to how how popular feeling is going, what popular concerns have become. I mentioned that there were academics involved in the national response on suicide prevention, and our group is part of a process referred to as the Living Systematic Review. This is a way of assessing emerging that's relevant to suicide as it comes through. So not waiting for studies to have been, very often these are studies that have before peer review, they're not yet published in major journals, but they're coming through into the public domain. And there's a process here led by Bristol and Swansea, with Manchester playing a part, on assessing its importance and getting messages out there into the public. And it's part of what happens to this information that's being assessed in this way is how it's feeding into the STP support that I referred to earlier. So we are channeling this evidence towards you to help you have the most up-to-date evidence. This is summarizing one of their most recent reviews, just published a few weeks ago, actually. And just to give you some of the main messages that this review reported, it wasn't at that stage finding any evidence, despite a lot of public concern, from the research data at least, that suicide or self-harm had risen during the period of pandemic. And remember, this is looking internationally at the evidence. Now, I think we are just beginning to get more reliable actual data coming through over the next weeks, so that will be updated. But at that stage, that was the finding. However, when the review team looked not at research evidence, but at reports of case series, so that's a different kind of evidence, they did find that COVID factors were frequently reported as part of the picture, as contributing to the stresses when people took their own lives, and in particular, fear of infection, isolation, and economic concerns. So again, just there's a consistency here about messages about isolation, the economy. Those are the things that are putting people, seem to be putting people at greater risk. And I mentioned child suicide. We've been part of a real-time surveillance operation which is run out of the National Child Mortality Database based in Bristol. This is a social service-based data collection. So it collects information from the CPOD, so CDOP, Child Death Overview Panels, CDOPs, which exist in every local authority. It's not particularly about suicide, but it collects data on suicides by people under the age of 18 across England. And using that information, we were able to plot week by week since lockdown and before what had happened to the number of child suicides. What we found was that there was what we referred to as a signal. So it's not proof because numbers are generally small, but there was a signal that suicides in the under 18s did rise in the first 8 weeks after lockdown. Now, we've expressed this in that very cautious way because the numbers are too small to draw definitive conclusions, and in any case, risk remains very low. This is the group in society with the lowest risk of suicide. Nevertheless, there did seem to be a reason to alert the wider system, so the NHS and care systems, to be careful about child risk. We were able to get information about what factors might be contributing to individual deaths, particularly if it was related to COVID, and that there were a number of factors. I think the important point here is there is no single factor. Some reports were about disruption to care or disruption to education. Sometimes it was about tension at home or isolation, but no single factor. It was a broad set of stressors that people were reporting. So an alert there, even if not definitive. And then we have finally this paper, which has come from the policy-related research group at UCL, which is it's an interesting study just published a few weeks ago about mental health services. And it's looking at, it's essentially asking mental health professionals for their impression of how services responded to the pandemic, and also how that affected service users. So it's an attempt to understand the changes in mental health services. And of course, we may see similar concerns and changes coming up in the next few months. So this is about the concerns and priorities of over 2,000 staff. So a large study and the number of results, but I summarized some of them on the slide. There was a particular concern about the difficulty of creating a therapeutic environment while at the same time exercising satisfactory infection control, which involved social distancing. So something we will have to become used to, have to work on and get right. There was a concern too about service users losing support, so their natural supports from friends and family, and feeling more isolated. And there was a particular interest in improving how we respond with e-contacts or telehealth in the community. So particularly, I suppose, for people who in the modern language are not digitally connected. So we talk a lot about digital connections with service users, but in fact, for many people, that seemed to be difficult, didn't seem to be working very well. And one of the main areas for future improvement will be in that practice. So just to finish, where does this leave us in terms of suicide prevention more generally? So if you apply those strategic priorities that I talked about earlier that come from the previous evidence, if we then apply that now alongside the experience and findings of the last 7 or 8 months, what does it tell us? Well, this is what a comprehensive local suicide prevention strategy might cover. So you can see we've got there are various groups who might need particular support. I've referred to today. There are actions by mental health services. I've mentioned crisis, people in needing acute care and so on, digital services. The need for partnerships across a sector, working with the media, for example, for community-wide interventions, and for collecting good data under real-time surveillance, contributing to what we understand nationally. But I think it's worth saying, to end with, that we are still learning. This is not something we know all about yet. There is good evidence coming through, good experience coming through, but we are still learning about risk and about safety, learning about what is needed for people and what will work for people. So it is very important that we continue this kind of learning dialogue. The work you're doing is extremely important. We have always learned a lot from the frontline suicide prevention experience. So thank you for listening, and whatever tier you're in, look after yourself and each other. And here's just a reminder of our research team from happier times, as you can see. Thanks very much.
Thank you, Lewis. That was hugely interesting, as it always is. I wonder if you might just stop sharing your screen, and then we've got some really interesting questions, and we might be able to see more of your face when you're answering those questions. First question I wanted to just put to you from the chat is from Neil Smith from Lancashire and South Cumbria. And I think this is a really interesting question. It's something that I heard a lot about people being concerned about from the beginning of lockdown, really, was the impact on domestic violence or potential increase in domestic violence and abuse. And Neil is saying, well, I might hand over to Neil to ask the question, but it's about, obviously in Lancashire, there's, sure you know, Lewis and other people may, quite a well-developed real-time surveillance system. And Neil's talking about the link they're seeing between suicide and domestic abuse through that. Neil, I wonder if I might ask you to just flesh that question out a little bit for Lewis, if that's okay.
Yeah, so we were talking earlier about risk factors and key risk groups, I suppose, associated with lockdown and COVID. So we've been tracking the incidence of domestic abuse, both as victim and perpetrator, linked to the real-time surveillance alerts since April, and we're starting to see trends. Interestingly, the higher numbers are with males that have a suicide marker, both as a perpetrator or a victim, or in some cases both. So I was just wondering whether that's being picked up nationally as a key risk factor. I know domestic abuse is obviously being talked about around COVID, and whether it is being linked to the RTS systems that are developing across the country.
Well, it's a really good question. Hi, Neil. Good to hear from you. It's a mixed answer, actually. And I think when we first started, we were, the paper I referred to, where we set out on the basis of what we already knew about suicide risk, who could we say might be at risk? And this was one group who we and other people identified. So there's no question that the various factors associated with lockdown, which include alcohol, they include being, of course, in a sense, stuck with people who might be intimidating. All of that would put some people at risk. And there was early evidence, you may remember, that calls to domestic violence charities supports increased very markedly in the first few weeks after lockdown began. In fact, the government did actually make some money available specifically for those charities, and made an exception to the stay-at-home message for people who might be vulnerable to domestic violence. So there were some quite immediate actions and recognition on this. Whether it's coming through in the data, I think, is a more unclear question at the moment. So I think it's fair to say that in some places that is the message, and in others it isn't. And so I know about Lancashire and South Cumbria, and that's probably the clearest message about domestic violence. Other areas haven't yet reported that. And in the self-harm data, where we've been able to collect information on, so now we're talking about non-fatal self-harm, people going to hospital, what do people say are the stresses they were facing? So far, the evidence is that they don't report domestic violence. And I think the question is, how are we sure we've got a system which is receptive to that message? So I'm struck by the number of people who report a sense of feeling trapped at home when they self-harm. And I just wonder whether that is a kind of code for being trapped with people who are intimidating. So that there may be other ways in which that domestic violence is indirectly reported. And it may be that expecting people to talk explicitly about domestic violence when they're in crisis and self-harming may not be enough. we might have to extrapolate what they're saying when they come into crisis or come to A&E departments with self-harm. So I think at the moment, I think everyone is very much aware of the risk here, but I can't say that it's yet become a consistent feature of the data.
Louis, are you aware of any, I suppose anyone could answer this question, but I'll ask you,